Dr. Hwang, I'm going to roll with the waterboarding. I think that
Yeah.
was my ENT's way of getting me back. That's my story, and I'm sticking to it. Every pituitary patient wants to know the same thing from their neurosurgeon. Can you remove all the tumor? But there's a question almost nobody asks. How do you get to the tumor? Before a single piece of tumor is removed, before the neurosurgeon even gets close to the pituitary gland, someone has to create the pathway. So who's responsible for creating that pathway? I thought you never asked. My guest today is one of the world's leading experts in doing exactly that. An internationally recognized ENT, rhinologist, skull-based surgeon, educator, and innovator at Stanford Medicine, Dr. Peter Hwang. Welcome to Talking Acromegaly and Pituitary with Tony.
Thank you so much, Tony. It's really an honor to be here.
Let's get right into it. What's the collaboration between the ENT surgeon and the neurosurgeon look like in the operating room?
Yeah, it's a great question. Kind of like what you just alluded to, I don't think most patients who are diagnosed with a pituitary tumor understand the team that is built around all the aspects of treatment that are necessary for successful surgery. And the ENT surgeons, we work right alongside the neurosurgeons and really do a lot of the surgery that's preparatory for getting access to the tumor. So we do that through the nose. And we work right alongside them as the tumor's coming out because we basically show the view that allows all the tumor to be removed. And then we collaborate on closure because, as you probably know, once you make a hole in the base of the skull to get the tumor out, you got to fix the hole. And sometimes that can be complicated. So we're definitely involved with that too. So we're really along for the ride in all aspects of care, as well as, post-operatively, we got to make sure the nose heals well. So I think that it's, a surprise to patients who haven't really been informed that there will be an ear, nose, and throat surgeon involved with their care. But as they move through the care, they do get a much better understanding about what we bring to the table and why it's important to have good ENT care as part of the treatment for patients with pituitary tumors.
You mentioned post-op. What is your role post-operative?
Yeah, well, you can imagine, the pathway, as you mentioned, the pathway to the tumor is through the nose. And we're actually using an airspace corridor that every patient has. So whether or not you have pituitary tumor, you have a nasal passage, you have sinuses, and these sinuses are air spaces around the critical structures of the skull base and around the eye sockets. And that's the corridor that we use. So that corridor is disrupted by surgery. We have to remove tissue. We have to move tissue. We have to decide, what are safe areas to cut out to preserve the function of the nose. And so if we do all of that during a several hour surgery, our responsibility afterwards is to make sure that that heals well, because we want to make sure that we don't give patients new problems with their nose and sinuses, because many patients don't have a lot of issues beforehand, but you can bet that they notice new things afterwards, especially if they didn't go into surgery with any kind of nasal problems. Some patients with acromegaly, will actually have nasal obstruction or other breathing issues due to the hormonal changes related to acromegaly, but a lot of the other non-acromegaly pituitary tumors aren't really associated with specific nasal problems. So we're trying to get patients back to where they were before surgery, and that requires a lot of careful postoperative evaluation.
That is interesting. Okay, when you look at a pituitary operation, what are the nuances, the nasal and sinus anatomy that you're paying attention to the most that patients and even maybe even physicians outside your specialty would never even think about?
Yeah, it's a great question. I don't think most people spend a lot of time thinking about their sinuses unless they do have a problem. If you have sinusitis, you know it because you can't breathe out your nose, you have drainage, you might have pressure, you might have headaches, you might have a diminished sense of smell. But most people who don't have those problems don't really think about what's going on here. It's kind of a black box. Um, but if you were to pass a scope through there, which is what we do, we create that corridor and pass a scope, you're going to go by a lot of very important structures that regulate airflow, structures that contribute to your sense of smell, structures that we need to preserve, such as your eyes, your eye sockets, your optic nerves, and vital structures like the carotid artery. All of these structures are lining the walls of the sinuses and nasal cavity. And on that journey from the tip of your nose to the pituitary gland, which essentially sits in the middle of your head. If you think about maybe drawing a line from here and here, and where they meet, that's basically where your pituitary gland is. So that's a deep space that needs to be traversed. And there are really important critical structures all along the way that we really spend a lot of time working around and preserving to have the best outcomes.
Dr. Hwang, before we move on any further, can you tell us a little bit about yourself and what led you to specialize in pituitary surgery, skull-based surgery?
Sure. So I am currently at Stanford University, and I'm the chief of the division of rhinology and endoscopic skull-based surgery. I started my career in medical school at UC San Francisco, University of California. And after finishing my medical school and residency, I knew that I wanted to subspecialize in the field of rhinology and endoscopic surgery. This was back in the late 90s. And at that time, skull based surgery was not done endoscopically at all. Or maybe it was being done at one or two centers and was really kind of considered very avant garde, almost experimental. Um, so that's the era that I entered, but I just happened to enter the field at a time of really rapid growth. And as you can imagine, thinking about something that used to be done either with open surgery or with big microscopes with tiny narrow views, the introduction of the endoscopes really revolutionized that. So I was very fortunate to be there at the advent of all this new technology being applied to this problem. So the field of endoscopic skull base surgery really grew in the time that paralleled my growth as an ENT surgeon. And that led me to incorporate endoscopic skull base surgery as a major part of my practice. And so my whole practice is exclusively nasal and sinus surgery and endoscopic approaches. And at Stanford, I was very fortunate to help recruit Dr. Fernandez Miranda, who's a world class neurosurgeon. I know that you know him and you've had him uh, on your program, and he has helped us to elevate what we can do endoscopically in the realm of skull base. So I've just been very fortunate to have a career that has been timed to these really tremendous advancements in the field, and I've really enjoyed being part of patients' journeys with who have skull base tumors, including pituitary tumors.
Doctor, how do you decide the safest surgical corridor to the pituitary, especially when every patient's sinus anatomy is different?
Yeah, it's a great question. First we want to look at just the basic anatomy because, like you said, everybody is different. So we're going through this airspace, but somebody, for example, might have a deviated septum, which is having the midline wall of your nasal passage that normally divides into two equal sides. Having that shifted to one side or the other could affect access. We usually need both nasal passages to get to the back because the neurosurgeons are working with instruments in both hands. So we have to create that corridor on both sides. So the first thing to do is look at maybe the scan, or we would scope a patient before surgery and try to figure out, what's going to be the narrower side, what's going to be the side that's going to be easier. Do we need to move the septum? Do we need to maybe remove some cartilage to allow that septum to open up? Sometimes we need to create even more space. So if somebody has a really large tumor, we need to open the sinuses, which normally aren't part of the approach to the pituitary gland. But if somebody has really extensive tumors, and at Stanford, we tend to see these patients where the tumor isn't just a little marble, it's like, a big tangerine. Well, then, the neurosurgeons will tell us, hey, we need maximum exposure. And that's going to factor into the way that we open the sinuses. We're always also trying to respect the function of the tissue. So I talked a little bit about, about smell nerves, the olfactory nerves. We want to preserve those whenever possible. And then breathing too. We don't want to leave scar tissue and things like that. So that fundamentally is how we would evaluate somebody in general, but then specific to, any given patient, they may have other issues. They may have had surgery before. They may have had a prior approach to the pituitary where tissue's already been removed. And then we have to figure out what's left. What can we work with? Or they may have had sinus surgery or nasal surgery because they had sinus problems before they knew they had pituitary problems. Or maybe they had a car accident and they fractured their eye socket and then the anatomy has changed there. So, there's a lot of nuances to the anatomy that I think are things that are just normal for us, routine for us, but may not necessarily be evident to a patient who is just trying to get their tumor out. And so these are some of the things that will come up in our discussions when we're educating our patients about our involvement in their surgery.
Doc, can you dive a little bit deeper in that from your perspective? What are some of the biggest technical challenges involved in a pituitary surgery that patients may never realize are happening behind the scenes?
Yeah. Well, there's a lot of thought about how big of an approach to create in order to make sure we can remove all the tumor. And I think like early on, we would see a lot of failures in maybe somebody's first attempt at a surgery because the approach was too narrow. So, think about like looking through a telescope, like you only see that. You can't see all the tumor. And so if you go to binoculars instead of a telescope, you already get better. You get like a bigger view, you get more view and, more access. And so we're constantly challenged to maximize the view that's guided in that discussion and collaboration with our neurosurgeon. Of course, we don't want to take out too much tissue, but we don't want to shortchange the resection of the tumor based on the approach. So we have lots of different ways of expanding the approach. And ultimately, it's the ideal that the patient doesn't even really know what we did, right? Because if we can open everything up in a minimally invasive way that restores all the function, and the patient just says, I know you were in there for 6 hours, but I can't really tell, because I can still smell, I can still breathe. Like that's our goal. But it's a challenge because when somebody starts out with no symptoms and you spend 6 hours in their nose, you can think about all the ways that you can actually give somebody new problems. And I always tell patients, like, we're going to keep working until we get all these problems solved. And sometimes, we just have no choice but to change the anatomy that makes patients, breathe differently or smell differently. But if we can restore function, then whatever we need to do during the surgery to maximize the view, we'll just do what's necessary because we can then put everything back. So that's the first challenge, is just making sure that we allow enough space for the neurosurgeons to completely remove the tumor. The other major challenge is at the end of the surgery, and I mentioned that a little bit at the beginning of our talk about the final phase, which is the reconstruction. And the reconstruction is extremely collaborative because there's parts of the reconstruction that the neurosurgeons will do, and there's parts that we do, and we work together, and we're discussing or debating what's the best way to get a watertight closure. So you can imagine for a lot of patients especially with the large tumors, you're left with a hole now between the brain and the nose, and the brain fluid will leak through that hole if you don't get a watertight closure. And back in the early days of endoscopic surgery, the failure rates of closure were very high because we're using what we call free grafts, which is basically cutting out a piece of tissue in your nose, and then hoping that a free graft, like a skin graft, would just stick. But you know what? 40% of the time, it didn't stick. And if it doesn't stick, the tissue dies and then the hole is opened up and then brain fluid leaks out. And that's where patients develop complications like meningitis. So there were some really significant innovations in reconstruction that used nasal tissue again, but we were able to keep the blood supply. And so the tissue was living tissue, not just a free like postage stamp that you just stuck on there. So that living tissue reduced the failure rate from like 30 to 40% failure rate down to like 5% or even less. And so that last phase of surgery, you're really glad the tumor's out, but the work isn't done yet. And that is the other phase that I think for ENTs, we find very challenging because, again, maybe somebody's already had multiple surgeries and, what's left in the nose, you still want to maintain function. You can't, use scar tissue to close the tissue, but you got to figure out a way so that the patient's not going to go back 5 days later, with meningitis and a leaky nose because brain fluid's coming out their nose. So that phase is, I would also consider to be one of the great challenges of endoscopic skull-base surgery.
Dwayne, you've talked in depth about your role as an ENT during surgery, but there was a time when this surgery was done without an ENT.
Yes.
How fair was that?
Well, I remember actually as a first-year medical student learning about the pituitary tumor being removed through the nose, actually, because it was one of those kind of gee whiz surgeries. And they used to do a lot of it at my medical school in San Francisco. And there was a world leader, Charlie Wilson. He was one of the, major figures in neurosurgery, and he mastered removing it through the nose. But I can tell you, at least at that time, I don't think Dr. Wilson, with all due respect as being one of the greats in neurosurgery, spent that much time thinking about the nose before or afterwards. And we would eventually get called on some of these patients to manage complications of the nasal passage. But, that we didn't understand that surgery to be a potentially collaborative surgery, although we did feel like there was potential for that. And I'd say when I first got to Stanford, which was in the mid 2000s, the neurosurgeons were removing tumors in that same way with a microscope, only with neurosurgery. And I think, we recognize because as ENTs, we use the scopes, the endoscopes all the time. That's how we think. We think, through an endoscope, not a microscope. And so, at the same time, if somebody is used to working with just a microscope and they think they're getting adequate results, it's hard to change minds, But over time, I was very fortunate to work with Dr. Griff Harsh, who was the neurosurgeon at Stanford before Dr. Fernandez Miranda. And, after a little while of kind of talking through it, he was open to the idea. And so the way that I shared that with him was, well, let's start with what you're comfortable with. And then at the end of the surgery, let's just put the endoscope in there and see. And so, we would prep everything with the microscope, big plastic drapes, and the microscopes, the operating microscopes are huge, as you might imagine. They take up a big footprint in a small operating room. And then we would finish with the scope. But, over time, over 6 months to 9 months, there was much more time spent with the endoscope than the big microscope. And eventually, the microscope just wasn't even in the room anymore. So I was very fortunate to work with a neurosurgeon who understood the value of the endoscope, because what he was realizing was he was missing tumor with the exclusively, microscopic view. And all it took was, 1 or 2 cases where he had that aha moment. Like, I can really see better with this. And so to his credit, he was eager to adopt the endoscopic technology. That's how I got involved with the endoscopic skull-base service at Stanford. And then, when Dr. Fernandez Miranda came, he was already, I mean, we recruited him for his expertise in endoscopic surgery. So we just continued to grow. But yeah, I would say, I'm aware of, there are very good neurosurgeons that are still doing the surgeries without ENTs. And I think, they're probably doing a good job. But I think that as patients become more aware of the different options, they're recognizing the value of having two different specialists working together. And I think you shared with me some of your experience having two specialists. And so you can reflect on that. But I think that, in the beginning, you had no choice, just the one neurosurgeon, again, back in the 90s, like you should just be glad that you're having it through your nose and not like a craniotomy, you know. But then over time, as the standards have kind of changed, I think nowadays it's much more common and almost expected to have the ENT and the neurosurgeons working together for these types of surgeries rather than just a neurosurgeon alone.
Dr. Hwang, I'm here to ask the questions that people having pituitary surgery want to know. One of those
Yeah.
questions is if a person's sense of smell is lost during the surgery, is it a way to get that sense of smell back?
Yeah. That's a really good question and a very valid concern. It turns out that um, the sense of smell nerves are most concentrated at the gateway to the sphenoid sinus. So inherently, if we need to make a big opening back in the sphenoid sinus, which is where the pituitary lives, or behind the sphenoid sinus, I should say, um, those nerves are going to be at risk. There's no surgery through the nose to the pituitary that doesn't go near those olfactory nerves. Fortunately, we have a much better understanding nowadays about where the highest concentrations of those nerves live. And there are ways of doing your approach to avoid injuring those high concentration areas of olfactory nerve. So, in general, I advise my patients that they should expect to recover their sense of smell, but it may take a long time. But there's always going to be cases, either because we had to do a much more extended approach than we thought, and we had to sacrifice some of that tissue, or there maybe just had been some abnormal distributions of the nerves. You can't see those nerves actually. It all just looks like pink normal tissue. So unfortunately, we can't map out where those nerves are during the surgery. So we just have to use our best judgment based on our experience. So, I tell patients there's a chance that they can lose their sense of smell permanently. And even in the best of hands, that's possible. So you do have to accept that risk, but it's really hard to predict, I would say. I would say somebody who has a much bigger tumor, we're going to be much more concerned that they may have a permanent altering of sense of smell. It doesn't mean that it's going to be completely gone, but it could be blunted. And, I would say if after 1 year there's no change in that, then that may be a longer term result. But everybody will have a temporary reduction of their sense of smell just due to swelling, due to blood clots in the nose, just recovering from surgery. So that's expected. But we do expect that to recover largely within the first 2 to 3 months, but sometimes it takes longer depending on, how extensive the surgery was. Fortunately, the area of olfaction is a area of great interest, especially at Stanford. My partner, Dr. Zara Patel, has invested a lot of her academic energy into new treatments for patients with olfactory loss. And specific to olfactory loss related to endoscopic skull-base surgery, she's done some great research on omega-3 fatty acid supplementation to stimulate growth of nerves. And she's shown that if you give that after surgery, there's a neuroprotective effect on those nerves that can help optimize recovery of olfaction. So that's something that's available over the counter, and it should be prescribed under the supervision of, an ENT who's involved in the care, because there's very specific doses that we would recommend. But that's one thing that has emerged out of research in this field, understanding, the need to really optimize that outcome. So that's one. We can use other nasal medications like steroid rinses to flush the nose out and reduce swelling in that area to optimize nerve function. And then there's newer technologies that are still being evaluated, platelet-rich plasma, PRP, which may have rich growth factors to help regrow nerves. And that is also being said by Dr. Patel here at Stanford. So we don't take it lightly that somebody's entrusting us with their sense of smell. And, there are things that we can do to preserve the sense of smell to the best we can, but there are always going to be situations where it's out of our hands or something unexpectedly happens that compromises the patient's sense of smell. Then we also know, though, that through our research, we are developing new ways to address that and hopefully optimizing patients' chances of having functional smell after this type of surgery.
Dr. Hwang, that steroid rinse was not pleasurable for me at all.
Really? Yeah.
No, the nurse literally had to hold me down. It was bad. I felt like I was drowning.
Really?
Yeah, I needed some help getting that
Did
done.
did you have it in the hospital or did you do it on your own afterwards?
I had it in the hospital.
Yeah, I mean, that's pretty unusual, I would say, to my experience for starting steroid rinses that early, because the tissue is pretty sensitive and you might have experienced burning and just feeling a little bit of kind of being underwater or waterboarding with all of that, so early in your experience. I would say for most of us, we start with a more gentle, just moisturizing spray in the beginning because the tissue is pretty sensitive. And we don't always use the steroid rinses. Budesonide is one of them. We don't always use them, but if somebody, has persistent swelling, if they feel congested, or they say, after a few weeks, yeah, my sense of smell doesn't seem to be coming back, then we might use it. So I think it's probably more tolerable a few weeks after surgery. And I would say in your experience may be, more unusual that somebody wanted you to have it right away. And perhaps it was related to some of the findings during your surgery. But I would say, there is the potential for like a burning side effect for some patients, even with buffered, salt and soda solutions. Sometimes the budesonide itself can be something that causes irritation or maybe preservatives. And so sometimes we can actually change the steroid or work with a compounding pharmacy that will fabricate it for us, so you don't have the same issues with preservatives that might be areas of sensitivity for patients. So there are options that we can work with, and that's part of the postoperative care that we talked about. Is adjusting medications, scoping patients, evaluating how's it looking, how's it healing. Does it look like it's supposed to after 1 month after surgery, or is there unusual swelling still? So those are the things that would factor into like my decision about whether somebody needs to use steroid rinses after surgery.
Dr. Wang, I'm going to roll with the waterboarding like you mentioned, because I can imagine I was not a very good patient early on, and I think that
Yeah,
was my ENT's way of getting me back. The waterboarding is exactly what was happening to me.
yeah.
I'm going to roll. That's my
Um,
story, and I'm sticking to it.
I don't doubt it. I would say after, going through all that surgery and just feeling like you're just trying to get back on your feet and just trying to get out of bed and somebody coming at you with a big bottle trying to stuff saline down your nose. I I don't think that would be a successful strategy in my practice, which is why we don't really do it. But perhaps like more communication between your ENT and you might have helped you understand why they were subjecting you to that. Yeah. Um, yeah, I'm sorry that you had that experience. And I think it's a lot to take because I would say that, the amount of congestion that we cause from surgery. I mean, just think about two surgeons working for 3 to 6 hours in somebody's nose. I mean, there's a lot of congestion after the procedure. So the rinses aren't even going to get in. And there's a lot of discomfort with having things like splints. Sometimes we put like protective silicone spacers in the nose, just like the oozing, the mucus. I mean, there's enough going on that's uncomfortable. Like adding the rinse to that early on, I think is a lot to ask. So we usually just moisturize with a simple saline spray bottle and have patients do that every hour or two while they're just getting through that first phase of recovery. And then usually we'll introduce the larger volume rinses, which actually are very helpful when timed, appropriately in the recovery period. That's usually for us starting like 1 week after surgery.
Dr. Wayne, you mentioned 3 to 6 hour surgery, and this is something that I've always been curious about. I often hear some people have surgeries that are 8 hours long. What is it like for you during an hours long surgery, 6, 7, 8 hours? Do you guys take breaks? Is it a time where you go over in a corner and sit down and say, okay, it's your turn, I'll be back? How does that work?
Yeah. Well, yes, I think that's, it's realistically, nobody really wants their surgeons to just power through and stand there for 8 hours. I mean, that's, it's kind of like when you fly a plane, you've got co-pilots. You don't really think about what's going on in the cockpit, but you trust that the plane is flying well, right? Because they worked out a system. And that's very similar to what happens in surgery because there are parts of surgeries. Well, I would say, ENTs in general are actually there at the patient's side longer than the neurosurgeons because the first hour to hour and a half is just the ENT approach. But I mentioned to you, like during the tumor removal, even though it's really the neurosurgeon removing the tumor, we're there too because you can't see the tumor without the scope. But that might be a time when it's like a less critical part of the procedure that my assistant might take over as the co-pilot to help the neurosurgeon while I take a break. And then similarly, we're working primarily, then the neurosurgeons can take a break. So, somebody's always obviously like in charge and really making sure that all the precision is there. But if you don't allow yourself to take a little break, you're not going to perform to the standard that you want. So it's just healthy for that. I mean, for our bladder's sake, for our stomach's sake, you have to take a break to be your best. But it really is like flying a plane. That's why there's co-pilots because that's just the nature of it.
Okay, you touched on this a little bit earlier, but I want you to dive in a little bit deeper. When a pituitary tumor extends beyond the sella into the nearby areas, how does that change your surgical planning and approach?
Yeah. Well, at Stanford, we have a conference before the surgery with all the team members every week. And we review all the cases that are going to happen. We have our radiologists involved who help us interpret the dimensions of the tumor. And that's our working session to figure out what's going to be the best approach. And we have lots of different tools that we can use, lots of different approaches depending on how far we need to go, how wide we need to go, how high we need to go. And of course, like once you get into surgery, the plan may change, but going in with a little bit of an idea that you've already communicated with, your collaborative surgeon and having a sense like this is what we're going to need to do, that really helps a lot. If somebody's tumor is, the grapefruit tumor and not the little pea-sized tumor, you already are thinking, okay, this is going to be that 8-hour surgery, not the 2-hour surgery, right? And other factors like there's going to be more bleeding. The scope view may not be as good because things are going to be more swollen. The reconstruction, there's going to be a much bigger hole left afterwards, and then from the neurosurgeon side, I mean, I know you've had many skillful neurosurgeons, that you've interviewed, they're going to also tell you like, well, then the bigger the tumor is, the more it's stuck to all these really critical structures in the brain that, are potentially at risk when you're trying to remove the tumor safely. So everybody's bringing their area of concern, and we're bringing all that together to say, okay, what's the most reasonable way to get to this tumor that optimizes outcome but minimizes risk? And that feedback from all sides is the collaboration that makes endoscopic skull base surgery so special. because we do believe that in the end, bringing all the different expertise that we have in the room, we can come up with that best path forward for a patient. And at Stanford, we're fortunate. I think our patients come out with really great outcomes because we have top-notch experts doing their best at what they do, and then there's a lot of communication and collaboration. So for sure, the bigger tumors are always the challenges. That's the one where maybe we can only do one surgery for the whole day. Like we just commit the whole day. We don't try to do two, just one, because we already know all the potential challenges there. And we do our homework beforehand, but a lot of times the plans change. There's pivots in the way that we approach the tumor or we reconstruct based on the findings in surgery.
Talked a little bit about losing sense of smell. What are some of the long-term changes, or just as importantly, the things that don't change that patients can expect after their pituitary
Yeah.
operation?
So sense of smell is definitely one thing that I will always talk about. The other thing, though, especially if somebody didn't really have this beforehand, is, they may breathe differently out of their nose. So we have to move all these structures, and the alteration in moving these structures, even though we try to put things back as close to how we found them as possible, there can be permanent alterations there. And, if you have effortless breathing before surgery, but you're struggling to breathe after surgery, you notice it every day. You notice it with every breath. You notice it during the day. You notice it when you're trying to go to sleep. It's very disruptive. And so helping patients understand that there may be changes to how they breathe through their nose is really important. Now, fortunately, a lot of those changes can be managed with things like the rinses, good postoperative care. If your ENT surgeon is checking on you and making sure you don't develop scar tissue, then that's going to be one reversible, cause of blocked breathing, right? Just removing scar tissue in the nose. But sometimes there can be other things that might require more formal surgical revisions, especially like the bigger tumor, the bigger approaches. I would say definitely the sense of, in addition to sense of smell, breathing through the nose is important. Some patients will have new sinus problems. So the sinuses will be draining differently because they've been altered. And so I do tell patients, especially those who have no history of sinus problems, that your next cold might turn into a sinus infection, whereas maybe before surgery it wouldn't have. And you should remember that your neurosurgical procedure may have affected your sinus function, and to keep that in mind. And that's also why we would want to be, postoperative care team to help patients understand that changes in the nasal anatomy as a result of pituitary surgery can affect susceptibility to sinus infections. Fortunately, it's pretty unusual that somebody actually needs surgery on their sinuses as a result of endoscopic pituitary surgery. But I've definitely had a few patients over the years where we just worked with all the medications we could, and ultimately they just benefited from having a sinus surgery. Or maybe they had surgery somewhere else and they came to me with a new sinus problem. So that's another issue. And then lastly, there can be changes in the external appearance of the nose. And that's pretty unusual, but I've definitely seen it. I've seen it where, for example, in a reconstruction, when you have to remove one layer of the nasal septum for the lining to reconstruct the skull base, you're left with cartilage that has only one lining supporting it. And sometimes the tissue you can lose some cartilage as a result because you took away blood supply from one side. That can sometimes lead to sinking of we call the dorsum, the top here, we call a saddle nose, it sags down, or the tip shifts. And that can be very disconcerting for a patient. Of course, that's not that common, but it's certainly possible. And so that's another thing that we would just want to mention to patients. Like, these are things that you don't think about because your brain is occupied by the fact that you have a brain tumor, right? And it's understandable that you're not really ready to process these other things. But if nobody mentions these possibilities to you beforehand, you're going to wonder why nobody did afterwards. So we do try to incorporate, this type of counseling for our patients, even if it seems minor, relatively minor relative to, the goal of getting the tumor out post-operatively in terms of, the quality of life. Of course, there's the quality of life of not having to deal with pituitary tumor again, as you all know. But you don't want to be left with a lot of quality of life issues that relate to the surgery because of things that might have been explained to you beforehand that could have helped you cope with them better, or due to the lack of adequate postoperative care that allowed some of these things to actually develop that might have not developed if somebody was more meticulous with how they managed you right after your surgery.
I've talked to people who have constant drainage, maybe up to even years later. You said that it doesn't happen often, but there's a possibility that someone may need surgery on their sinuses or something of that nature later on. Is that a
Yes.
symptom or reason why someone would need that surgery later on?
Yeah. Well, certainly, if somebody had unexplained new drainage, even if I wasn't the surgeon that did the pituitary surgery, I would want to be investigating sinus causes of excessive nasal drainage. There can be occasionally cases where just moving all the tissue kind of rewires the nose, and just a runny nose, like just clear, not even infected mucus is the problem. But we have treatments for that too. So we can do things like radio frequency ablation. Things can be done in the office to try to turn down the volume or the activity of those nerves that stimulate mucus production. So I would say for anyone, even if you were a patient and you didn't have an ENT involved with your care for your pituitary surgery, if you have residual nasal symptoms or new nasal symptoms, definitely go see an ENT, and there is a whole subspecialty of ENT, which is my field, which is only dealing with nasal and sinus problems. We call ourselves rhinologists or rhinologists and endoscopic skull surgeons. I mean, general ENTs can certainly manage these too. But if you said, well, I have a very special case because I want somebody that understands the kind of surgery that I had, that if you see somebody who specializes only in the nose and sinuses, you will have a very understanding conversation from from your provider's standpoint, that they get this, they've seen this, and hopefully they can either offer medication or a procedure to reduce those symptoms. You don't need to live with these things um, necessarily. You should definitely have the evaluation, even if you didn't have an ENT taking part in your pituitary care.
Dr. Wang, we are at the point in this conversation where we have reached the rapid fire five. Are you ready?
Okay, I'm ready.
What would you be doing if you were not an ENT rhinologist?
Um, so I'd probably be an inventor because that's what I wrote down in my little grade school. When I grow up, I want to be a blank. And I'd like to think that I would have invented something that would help a surgeon eventually. And actually what I do on the side is I have my own startup. So in some sense, I actually am still an inventor because I'm working in medical devices. But I would say an inventor of what I don't know, but that would be my other dream job.
While in the office, coffee, tea, or something else?
Uh, Coffee, um, espresso based coffee would be
Early bird or night owl?
definitely early bird. No alarm clock. I wake up between 4:30 and 5 every day without 'em.
If I handed you a free plane ticket right now, where would you go?
Good question. I would probably go to, let's see, I'd probably go to the South Pacific. Remote, no phone calls, take a little break, and then head back to Stanford and get back in on the endoscopic skull surgery team.
What's the most used app on your phone besides your email?
Um, yeah, it's a good question. Well, I hate to admit it, but my medical record app which lets me follow up on my patients, is probably my most used app. So it's hard to leave work a little, separate that out, but I do enjoy being able to get access to my phone to look at all the medical records for patients and my schedules, for surgeries and things like that. So it's an innovation, but it does kind of keep work in your pocket a little bit, but I'm okay with that.
Well, Dr. Hwang, we've learned that you consistently care for your patients while waking up early and inventing things.
Well, there's some truth to that. You're very kind to put it all that way, but in the ideal world, yes. But
Sounds like a plan. Dr. Hwang, you have been a pleasure to speak with today. I am so glad you were able to be here joining me. And I hope that we have the opportunity to have another conversation if you would ever be open to that.
absolutely, Tony. I really appreciate how you're serving this community with your work here. I know there's a lot of work. I know you don't think of it as work, but there's a huge amount of effort to bring this type of education to the community. And I know that you're appreciated, and I appreciate being part of that. So thank you so much for this honor to join you for this podcast.
To the people listening, since you're still here, I'm sure that you found a lot of interest in this conversation. So make sure to support the channel by hitting that subscribe button, liking the video, sharing it with others, and leaving a comment below. You can also follow me on all my social media platforms and stay right here for more real conversations, expert insight, and inspiring stories. Dr. Hwang, thank you once again for your time. Thank you for joining me today, but most importantly, thank you for talking acromegaly and pituitary with Tony. It's been a pleasure having you.
Thank you, Tony.
Everyone, thanks for watching.